Hi everyone, let's assume a 69-year-old male is coming to your OPD and he complains of a unilateral hearing loss, and when you examine him you find that the Weber is lateralized to the opposite side, the knee is positive and the ABC is reduced, and this diagnosis of sensorineural hearing loss is confirmed by a photonodogram. In that case, what will you do? Will you just ignore this as a diagnosis of presbyocusis and prescribe him a hearing aid trial, or will you suggest a new investigation, that is MRI, to be done to rule out something which is very important? Yes, the second thing is what is to be done. And what are we trying to rule out there? We are trying to rule out an acoustic neuroma, which is the most common tumor of the CP angle. Okay, so this acoustic neuroma is actually a misnomer. It arises from the area of internal auditory meatus and then goes to the CP angle. Why is it called a misnomer? Because this acoustic neuroma does not arise from the acoustic nerve, nor is it a neuroma. It is in fact a schwannoma. It is arising from the Schwann cells of the vestibular nerve. Okay, and it is seen more in the elderly population, and so you might mistake it for a presbyocusis when the patient comes with sensorineural hearing loss, but it is unilateral usually, unless it is due to a syndrome, that is NF2, neurus fibromatosis 2, where it will be bilateral. Okay, so what are the things that we learned about vestibular schwannoma? It is a benign invasive tumor. What is the problem with it being invasive? The internal auditory meatus and the CP angle are areas which are very much constrained in space. So if it grows larger in size, it can cause a lot of problem, even though it is a very slow growing tumor. Okay, now this vestibular schwannoma, it is non-encapsulated and is seen in the elderly. Okay, and when seen in the elderly, usually it is unilateral. Bilateral, if it is seen in the young, then you will have to suspect a case of, yes, neurofibromatosis 2. Okay, in that case it will be bilateral vestibular schwannoma and is seen in the young. Okay, so that's about vestibular schwannoma. And what did I tell you? It is seen to arise from the internal auditory meatus. As you can see here, you have the superior vestibular nerve above, inferior vestibular nerve below. They are separated by the falciform crest, and it is the Bell's bar which separates the facial nerve from the superior vestibular nerve. Okay, so this superior vestibular nerve and inferior vestibular nerve, which is the most common cause of vestibular schwannoma, it is the inferior vestibular nerve. Even though they are almost equal in incidence, when a question is asked, the answer should be inferior vestibular nerve is the most common cause of schwannoma. Okay. Now, what happens to this schwannoma? Initially, it arises in the internal auditory meatus when it causes compression of the inferior vestibular nerve, the 8th cranial nerve, in the cochlear part of the 8th cranial nerve, as well as the 7th cranial nerve, that is the facial nerve. Okay, so initially the patient will present with unilateral sensorineural hearing loss. Why is it not having vertigo? The tumor itself is arising from the vestibular nerve, right? And it is also compressing the nearby superior vestibular nerve. Then why is it not causing a vertigo? The reason is that it is a very slow growing tumor, so it gives the body times to decompensate for the increased firing or the excitatory problem which is being caused by the compression. Okay, so that is why this tumor does not cause vertigo initially. Okay, it is in fact causing only an unsteadiness. There is no vertigo in vestibular schwannoma. It is actually presenting with the hearing loss, which is slow and progressive. In some cases it can present with a sudden onset hearing loss when there is sudden hemorrhage. In that case, when there is a sudden ischemia occurring, all those things can result in a sudden sensorineural hearing loss. Otherwise, it usually presents with a slow sensorineural hearing loss with tinnitus. Okay. Now, what is the other nerve that can be involved? As you can see in this picture, it is the 7th cranial nerve. Okay, that is the facial nerve. Which part of facial nerve is involved? It is the sensory part of the facial nerve which is involved first. Okay, sensory part of the facial nerve gets involved first. Now, how will you check for the sensory part of the facial nerve? We know that the posterior-superior part of the area, the posterior-superior part of the axillary meatus is being supplied by the facial nerve, and that is why this is called as an important sign when there is a hypoesthesia in that area. What is that known as? This is what is called as Hitzlsperger sign. Okay, Hitzlsperger sign. In Hitzlsperger sign, what is happening? There is hypoesthesia in the area of the posterior superior part of the external meatus, and when this Hitzlsperger sign is present, it is indicative of a vestibular schwannoma. But Hitzlsperger sign is not something which you commonly elicit. Okay, it is not very common for you to elicit because it is usually accompanied by the auricular branch of vagus or the Arnold's nerve. So you can't simply isolate the sensory part of facial nerve in the external meatus and go on to stimulate it. Okay, so it is rather uncommon for this sign to be present. Okay, even though theoretically you say this is the first sign to be present, Hitzlsperger sign, it is uncommon. Then what else will happen? It later goes on to grow into the CP angle, right? So the superior part of the schwannoma goes on to the petrous part of the temporal bone, where you have another nerve, another cranial nerve. What is that? The 6th cranial nerve. So it can go and compress the 6th cranial nerve. Apart from that, what else you can compress? You have the Meckel's cave, where you have the trigeminal ganglion. Okay, trigeminal ganglion is seen here. The 6th cranial nerve also can get involved. And the superior pole, it has got a growth towards its superior pole. Then that results in the involvement of the trigeminal ganglion as well as the 6th cranial nerve. So when the 5th cranial nerve is involved, what happens? There will be hypoesthesia in the area which is supplied by the ophthalmic, maxillary and mandibular nerve. Okay, so the region which is supplied by the ophthalmic nerve is what is responsible for the corneal reflex. Okay, so this reflex is something which is that is going to be affected first. Okay, and so you can assess the corneal reflex in a patient who presents with the complaint of sensorineural hearing loss. And what is the sign known as? This is what is called as Thiel sign. The loss of corneal reflex in vestibular schwannoma is what is called as Thiel sign. So you will have to look for corneal reflex. The corneal reflex, the efferent nerve is the ophthalmic nerve and the efferent nerve is the facial nerve. Okay, so only when the sensation from the cornea is lost due to the involvement of the ophthalmic part that is coming from the trigeminal ganglion due to the compression by the vestibular nerve, the schwannoma, when it is compressing on the trigeminal ganglion in that area, that results in loss of the corneal reflex. Okay, so this is one of the earliest signs that you can elicit, even though Hitzlsperger sign is theoretically what is the first sign that is seen. Okay, now when the 6th cranial nerve is involved, what happens? There will be double vision. Okay, double vision, because the 6th cranial nerve supplies the lateral rectus and that is being involved here. So that can result in double vision. Now when the tumor goes into the lower pole and goes on to involve the 9th and 11th cranial nerves, what can happen? And the 9th and 10th cranial nerves are involved, it can result in difficulty in swallowing or dysphagia. Along with dysphagia, there can be dysarthria, okay, dysphonia. All this can happen because of the involvement of the 9 and 10 lower cranial nerves. Okay, so this is how a patient with acoustic neuroma presents. Acoustic neuroma patient will be presenting with a hearing loss, and when you are examining, but you will be finding vibrissae lateralized to the opposite side, and doing the Rinne's test, it can be positive or a false negative Rinne also is likely to happen, and ABC will be reduced, Schwabach also will be reduced. Okay, now on PTA there won't be any AB gap and there will be a sensorineural hearing loss. When you are doing a speech audiometry, the speech discrimination score will be very poor. Okay, so when you are increasing the intensity of the sound, the patient initially will be hearing better, but later on he won't be able to appreciate anything. The speech discrimination will become poorer, and that results in a curve which goes up and then comes down like this. Okay, when you are plotting against the intensity of the sound, and that is what is called as rollover phenomenon. Okay, all these things you have learned, I am just revising it for you. Okay, so rollover phenomenon will be present, and when you are doing a CC, it will be only 0 to 20%. There won't be any recruitment. Recruitment is seen in cochlear deafness. So in mini CC's recruitment will be present, and the CC will be 90 to 100%. But in this case, the CC is only 0 to 20%. Okay. Now, what happens when you do a stapedal reflex? The stapedal reflex, the decay will be increased. There will be a decay happening. That is, when you are increasing the time to which the sound is exposed, the stapedal reflex, there will be less of the stapedal reflex. You will have to give more sound to the patient for the stapedal reflex to be elicited, and it will be taking a longer duration for it to happen. Okay, so that is happening due to the stapedal reflex decay, because all nerves have a chance of decay. Okay, when you are exposed to repeated same intensity, that can result in decay. So that can be elicited by doing the stapedal reflex decay test. Okay, and that is a part of the impedance audiometry. The stapedal reflex will be preserved, but there will be decay of the stapedal reflex. Okay, the threshold tone decay test also can be done. It shows a tone decay of more than 25 dB. Okay, but which is the best audiometric test that can be done for diagnosis of this CP angle tumor, that is acoustic neuroma? What is the best diagnostic test? It is in fact BERA. Okay, BERA. With BERA you can know exactly what each wave represents, right? The first wave is for the distal part of the 8th nerve, second wave proximal 8th nerve, the third wave is for cochlear nucleus, and the fourth wave is for the olivary complex, right, superior olivary complex, and the fifth wave, which is the largest wave, you have the lateral lemniscus. Okay, lateral lemniscus, that is the largest wave, the fifth wave. Okay, so what are the things that you are looking for in a BERA? In the BERA, first of all, we will be looking for the interpeak latency between 1 and wave 5. If it is more than 4.4 milliseconds, that is suggestive of a CP angle lesion, because wave 1 is corresponding to the distal part of the 8th nerve, and after that there is compression by the tumor, and because of that there will be an interpeak latency of more than 4.4 milliseconds. Okay, so the interpeak latency more than 4.4 milliseconds is suggestive of vestibular schwannoma. But in certain cases what happens is that the blood supply also will get compromised due to the tumor compressing it. Okay, the blood supply to the internal auditory meatus area, it gets compromised. So wave 1 and wave 2 also will be absent, and since wave 5 is the largest wave, it will be the last wave to disappear. In that case, to assess whether the patient is having a CP angle tumor or not, what you can do is you can look at the interoral latency. Okay, if the interoral latency when it is done is more than 0.3 milliseconds, okay, interoral latency more than 0.3 milliseconds, that is between the other ear and this ear, if the latency of wave 5 is more than 0.3 milliseconds, that is indicative of a CP angle tumor. Okay, so that is what you have to assess for if you are not able to look for the interpeak latency. Okay, but if you are asked what is the best investigation that is to be done for a patient who presents with symptoms suggestive of a vestibular schwannoma, it is not BERA, it is in fact a radiological investigation, and that is gadolinium enhanced MRI. Gadolinium enhanced MRI has to be done. Now, what is the finding that you will get in a case of gadolinium enhanced MRI? You will be able to see a peculiar ice cream cone appearance, as you can see here, when the tumor has grown from the internal auditory meatus and then went into the CP angle. Okay, only by the time it reaches the CP angle, there will be the features like loss of corneal reflex present. For it to cause loss of corneal reflex, there should be about 2.5 to 3 centimeter minimum size should be there for the tumor, okay, to cause loss of corneal reflex. And if there is loss of corneal reflex present, it is indicative that tumor has spread into the CP angle, and on doing gadolinium enhanced MRI, you can get a typical ice cream cone appearance. Now, why do you have to do an MRI? Is it just for the diagnosis? No. When you are doing an MRI, if there are certain cystic areas, then it can be easily identified with MRI. If there are cystic areas in the MRI, then you will have to do surgery. You can't just go and wait and watch. Okay, cystic areas when present, you will have to do surgery for the patient. Okay, now what are these cystic areas and how does it appear? In the histopathology, schwannoma appears as having antony A and antony B bodies. Okay, antony A are tightly packed areas. Antony A are tightly packed areas, and you will be able to see Verrucke bodies there. Verrucke bodies will be present, whereas antony B are loosely packed and they are cystic in nature. Okay, what is the problem with this cystic area? It can suddenly grow and can cause a lot of problems, because if there is a sudden growth in that area, it can result in the 9th and 11th cranial palsy, right? So if it is a cystic type of tumor, then you will have to advise the patient to undergo a surgery as early as possible. So that is the importance of looking for cystic areas in MRI. Okay, this is the histopathology which is obtained when you have done a surgery for the patient, and in that case you will be able to see antony A where there are tightly arranged the arrangement of the cells are seen. That is what is called as antony A, where you can see the Verrucke bodies. In antony B, you will be able to see cystic areas. Okay, and that when antony B areas are present, you will have to go for surgery. Okay, so what are the things that you do when a patient comes to you with features suggestive of a CP angle tumor? First of all, you will have to do an audiogram, and the audiogram will confirm it as sensorineural hearing loss. And what else will you have to do? You will have to check for if the patient is having a cochlear or retrocochlear lesion, And how will you differentiate between a cochlear and retrocochlear? That is by doing speech audiometry. If there is rollover phenomenon, then it is suggestive of retrocochlear lesion. And the threshold tone decay when it is more than 25 decibel, that is also suggestive of retrocochlear lesion. And the sepidal reflex decay also will be present, and there will be no features of recruitment which are seen in the cochlear deafness. Okay, then you will have to do a BARA if it is available. That is the best audiological investigation to diagnose a case of CP angle tumor in BARA. But what are you looking for? You will be looking for interpeak latency between wave 1 and wave 5, and also intraoral latency more than 0.3 milliseconds with the other ear. Okay, that is also suggestive of a CP angle tumor. Okay, now to diagnose the tumor, you will have to take an MRI with gadolinium enhancement. You can know exactly where the tumor is, and you can plan for surgery.